my friend.
All right.
Glad to have you along for this Monday edition of Closer Look. I'm Rose Scott.
I'm Jim Burris. This afternoon, we continue our discussion about a bill making its way through the Gold Dome that would increase the scope of practice for optometrists in the state. Now, some ophthalmologists are against the move. As a refresher, ophthalmologists are MDs, eye surgeons. Optometrists are not medical doctors, but instead primary eye care providers. They attend optometry school, not medical school. Well, on Friday's show, we heard from Dr. Baker Hubbard, a local ophthalmologist.
And that's the dangerous part about this bill, in our opinion, is that it would put patients at risk who don't maybe understand the difference between an ophthalmologist and an optometrist, you know, what the difference in training is. And one's an eye surgeon, one has great skills in other things, but nothing in eye surgery.
Well, today we'll get the other side of the argument, this time from two area optometrists. Joining us in studio is Dr. Paul Ajamian, past chairman of the American Board of Optometry, and Dr. Meredad Sadat, leader of the Georgia Optometric Association. Thank you both for joining us.
Thank you, Rose. Thank you, Jim.
And Dr. Ajamian, I want to start with you. Optometrists are considered the primary eye doctor for most people. You can diagnose diseases and prescribe medication. But when you recommend a patient of yours to see an ophthalmologist, it's for what reason, for example?
Well, I've been blessed to have a career that encompasses working with both optometrists and ophthalmologists. Mm-hmm. And ophthalmologists spend a great deal of their time and training in surgery. And so when someone needs cataract surgery, for example, or has a retinal detachment, that's when we would send them on to the ophthalmologist.
And same for you, Dr. Sadat?
Absolutely. First of all, thank you for having us here both as well. But I 100% agree with that. We're in primary practice, and we're able to take care of patients through and through until the time for surgery is necessary in most cases.
So let's talk about what's at the core of this proposed legislation and the controversy, which has to deal with injections around the eye. Can you understand their concerns that an optometrist should not, based on training, be the person to perform these injections? Can you understand an argument? And you can, respond.
Rose, what's so interesting is that I had a flashback when I was hearing that sound clip from the doctor from Emory Friday that, I'm old enough to remember the 70s and 80s when we were told that by ophthalmologists and the public was told by ophthalmology that when we obtained the rights to use dilating drops to look in the back of the eye or topical antibiotics that we were going to blind people and a lot of harm was going to be done. So this is just a repeat of what's happened over and over as we've expanded our scope to keep up with technology. I mean, we love this profession. We spent 4 years just studying the eye, and this is a profession like all health professions that's on the move. And we want to keep up so that we can serve the patients of Georgia that we love and provide that access to care.
Dr. Sadat, can you understand the argument that they were making Friday about the training that's involved? And there was quite a gap in terms of the hours that optometrists and ophthalmologists go through.
I can understand their perspective. However, I would beg to disagree. In medicine, the ophthalmologists train in 4 years of medical school where they're learning about all different parts of the body. And then they do a 3-year residency, which is concentrated in and of the eye. In optometry school, we study 4 years concentrated solely on the eye, through and through, meaning that we do train in how medications we may prescribe to a patient interact with other partly bodily functions, such as blood pressure medications or diabetic medications. But that doesn't mean we are not trained fully through the eye. We are trained in injections as well throughout optometry school. In 1995 is when my university started training students to do injections. So it's been 20 years plus that the state of Tennessee and other states have been able to do these treatments on patients. However, Georgia doesn't allow that. And imagine being trained to do something and learning a profession, a skilled profession, whether it be a plumber or a hairdresser, but not being able to utilize your services for your clients all the way through. And that's kind of where we feel that if I was trained to do this, and I've been trained to do this for years on end, and I have to get continuing education to be able to do this, why am I not able to treat my patients like I've been trained?
And that's why I can't totally understand their point of view, Rose, because we're really one of the few healthcare professions in Georgia that can't use injections as a mode of medication delivery. RNs, LPNs, dentists, DOs, a lot of other professions other than medical doctors do injections without the so-called 20,000 hours of training that we've been told is necessary. And so a lot of patients themselves get injections by family members and loved ones, whether it's infertility or diabetes or an EpiPen. And so we feel the time has come for us to add that drug delivery system to our armamentarium. We're already prescribing medications orally and topically that affect the rest of the body. We want the ability to just treat the local site that needs to be treated in certain cases.
But Dr. Ajamian, wouldn't you agree that an EpiPen injection is far different than using a needle on an eyelid?
Not really. I mean, an injection is an injection, and we're used to working around the eye. We take out foreign bodies. It was also said Friday that we don't do procedures. That's the difference between optometry and ophthalmology. We do lots of procedures around the eye. So we're digging out foreign bodies out of the cornea and the fairly deep tissue of the cornea. Something gets embedded in the lid. We're taking that out using needles and syringes. So for someone that isn't used to the eye, it might be different. But for a profession that is used to working around the eye every day, this is a natural extension of what we're trained to do, what we're already doing. And surrounding states have it. We just want to be able to do it here.
And Dr. Sadat, I understand that this would be used to treat what's called a chalazion, which is a clogged tear duct. Why would an optometrist need to use a needle to do this procedure?
Well, I think there's a little bit of a definition error on that part right there. So it's not really a clogged tear duct, but more of a clogged gland that helps produce body oils to help moisturize the eye. It's called the meibomian gland. And in many cases, these things can become infected, or they can be sterile. The key to this is one of the major treatments and easiest treatments in doing these things is by giving a localized injection. Now, there are other ways, such as a capsule, but that like a pill, but that has other side effects in the body as well. Giving a drug directly to that area in very limited amount can rectify the problem within a matter of a few days versus taking a pill that has side effects, especially if patients are on other medications that can have interactions that way. So local drug administration is key in giving this, as well as being able to give a thorough care to our patients versus having to send them out to another professional to do the same care that I could be able to do for them.
And are we only talking about injections to treat a chalazion, or are there other conditions that you all would use injections for under this bill if it passed?
Subconjunctival injections are used now, steroids for inflammation that isn't responsive to drops or pills. And there are future drug deliveries that we're very excited about that will help with compliance. Patients that can't afford glaucoma medication, for example, could have a depot injection that's long-lasting under the conjunctiva. Again, tissue that we're very comfortable injecting into. And, again, the flashbacks to the horror stories and the falsehoods about us sticking needles inside the eye. That's not what we're going to be doing. Retinal specialists do that. That's not something that's included in this bill. The other big thing, Jim, is access to care. I mean, studies have been talked about that mention that it's only 30 minutes to an ophthalmologist anywhere around the country. That might be true, but try calling an ophthalmologist, especially a skilled subspecialist, and getting a new appointment. There are delays in getting in to see ophthalmologists. There's a stable level of ophthalmology being trained, yet the demand in Georgia alone, never mind nationwide, is going to increase a tremendous amount, and we're not going to be able to meet that gap without optometry being able to deliver these key procedures at the point of service rather than delay care and send them somewhere else.
You mentioned access to care. We talked about this last week. Dr. Baker Hubbard from Emory, he actually disagrees with that statement. Here's what he said.
There is a good study that looks at drive times from the home of patients to their nearest ophthalmologist versus the nearest optometrist. Turns out that 90% of Medicare beneficiaries have access to an optometrist within 15 minutes and access to an ophthalmologist within 30 minutes. So it's a 15-minute drive time for 90% of the population. Not enough of a difference, in our opinion, to compromise patient safety standards.
Dr. Sadat, what do you think?
I'd like to comment on that because I actually practice on the west side of Atlanta, further out from the city, and it is about a 30 to 35-minute travel time for my patients to get into the city to be able to get treated at facilities that are with ophthalmology care, and we do make those recommendations when necessary. However, let me state this very clearly, that many of my patients, when I make the recommendation for cataract surgery and they have to travel into the city to get that care, they're very apprehensive about it, and they are really reluctant to drive on the highway. These are elderly patients that may be in their 60s and 70s and having to go that far into the city. And they're always asking if there are back roads that I can take. Is there a near ophthalmologist to me that I can see? And in many cases, the answer is no. So if you imagine I'm in the west side of Atlanta, let's think about our areas like Vidalia, South Georgia, further south of Macon. I mean, those patients are really in rural areas. When we talk about the number of optometrists in the state of Georgia, there's over 1,000. In ophthalmology, there's 350. So we're really not balanced when we come to ophthalmology versus optometry care. So if we can give those 1,000 optometrists the ability to take care of those patients a little bit better, that would benefit our patient population extravagantly, I believe.
I want to get back to the training that will be required under this bill, because it did mention that optometrists would be required to take 30 hours of what they call injectables trainings. You just said earlier, though, that you all receive enough, in your opinion. So these 30 hours would do what?
Well, it was a stipulation written into the law that we agreed to this as a refresher course and to stay up to speed with the newest and most current technologies, and we've agreed to that. And we don't argue the fact that we should be better trained to handle our patient care. So we've accepted that responsibility and said, sure, if you're going to allow us to be able to do this, we will all take refresher courses. And if you think about it, a 30-hour course is not a weekend course as has been stipulated. I mean, unless you're going to be taking classes 24 hours a day on a Saturday, which is not realistic. This is a week-long session that would take place over time, and we'd be practicing throughout that course of that time. One last thing that I'd like to say is, as we advance in medicine, things like robotics are becoming very necessary or easier for technology when we go to the hospital for treatment care. What patient wouldn't want robotics care if they could have it when they're doing heart surgery? In the future, as is coming down the line already, we see things like microneedles that are being developed, microscopic needles that can be used that are very bendable and flexible and can't really penetrate through the tissues that would harm the body. So if we have this legislation invoked and put in place, those microneedles could be used in patient care and also alleviate the apprehension of penetration through the eye and globe and those kinds of things.
Dr. Ajamian, you mentioned a moment ago other states around us that do allow this increased scope in practice. And I asked the doctors from Emory on Friday the same question. Is there any evidence that in those states there are more complications when optometrists perform these procedures as opposed to ophthalmologists?
We have not been presented with any evidence. And again, none of the laws that have been passed have been repealed. Optometric malpractice rates remain the lowest of most professions, most health professions in the country. And, if there were horror stories as have been propagated, we would know about it, and bills would be repealed, and people would be hesitant to go forward. Tennessee has had this bill for 15 years. There are 8 or 9 other states where it's directly written in, and then others are silent on it, and those doctors are taking advantage, again, of technology that benefits patients.
And we're just about out of time, but what do you think the likelihood is of this passing this session?
Oh, we're very optimistic. We feel like the good guys always win. We have over the years. And again, despite all the horror stories that the public hears, we urge you to allow yourselves access to this kind of care, to call your House of Representatives member and ask them for support of Senate Bill 221. We're very optimistic.
Optometrist Dr. Paul Ajamian, Dr. Mirhed Sadat, a leader of the Georgia Optometric Association. Thank you all so much for coming in. We appreciate the time.
Thank you.
Thank you again for having us.
Thank you.